Hi, everyone. Welcome back to the Doc Talk podcast. I'm Dr. Shazma Mathani.
And I'm Dr. Sheila Wijaya-Singha.
How is your week going this week, Sheila?
Pretty good. It's almost spring. I'm excited. We needed this.
Yeah, same here. It's actually really nice to see the snow melt and like sunshine. I mean, Edmonton's a pretty sunny place, right?
I miss that sun.
I know it is. You miss it when you leave or when you go somewhere else. Even in the winter, it's so like blue and sunny here all the time. But it's definitely nice to start feeling that warmth and like smelling spring in the air. You know what I mean?
That's my favorite Edmonton smell. Because I know Edmonton is so cold and everyone asks me about that being in Toronto now. But it is my favorite moment when you get that smell and it's like bright, sunny, and you know it's about to shift. It's beautiful.
Exactly. Oh, love it. Okay, so today we're diving into heart disease. This is a leading cause of death worldwide, but people still don't know what their risks are or realize that it is actually this deadly. So we're going to talk about heart attacks, strokes, and why women's health is so overlooked when it comes to heart health.
And Shaz, I think it's such an important topic because one of the reasons that people still see heart disease as a man's disease, even though it's the number one killer of women in Canada, the symptoms can be different and we are less likely to get the right tests and treatments. So we're going to get into this all today because it's such an important topic. I certainly see it in my office in terms of the impact of heart disease on people's lives, and you see it in the emergency room on a regular basis as well.
Absolutely. But of course, as always, let's first hear from a listener.
Hi, Dr. Shaz and Dr. Sheila. My name is Kellie, and I love your podcast. I have a question regarding women's heart health. My understanding is that female hormones and how they change through the lifespan have an effect on our heart as we age. I'm in my late 30s, so perimenopause is on my brain. Are you able to dive into any of the current research demonstrating differences in heart health and heart disease symptoms in males versus females? How can we advocate for ourselves and our loved ones if we think something is truly happening and standard screenings and tests aren't showing anything? Thank you.
That's such a great question. And I wish I had more of an answer around research because there's an imbalance in research when it comes to women's health and men's health. And in particularly, we know that 6% of research in Canada in terms of health-related research is on women. So 6%, we make up 51% of the population and 6% of research is on women and women's health. And this is something that I think is changing. So we'll be able to answer Kelly's question in terms of some of the generalities around risk factors for heart disease. But in terms of research, that area is still growing. We have a really interesting study that came out at Women's College Hospital where I work around when we look at mammograms, we can actually see calcification in the arteries in the mammogram. And actually that relates to potentially an increased risk of heart disease. So we're looking, those things are emerging research findings and it's really exciting. But again, right now, there's a disproportionate number of studies that are done on women compared to men.
And I think the more we talk about this and the more it becomes a public conversation, hopefully the more it pushes researchers to include women in their research studies, because as you said, we are 51% of the population. Now, before we dig into all of this, I want to set a foundation in terms of what we're talking about and kind of what the definition of heart disease is. And so heart disease actually includes multiple different problems related to something called atherosclerosis, which is essentially a buildup of plaque inside the blood vessels that supply things like the heart and the brain. And remember that blood is what brings oxygen to these tissues, and that is required to live. And so when these plaques exist, they're a lot more likely to have a clot form. And when there's a clot, that can actually completely block off the blood vessel and block off blood flow to either the heart or the brain. And that can then cause either a heart attack if it's affecting the heart blood vessels, or a stroke if it's affecting the brain blood vessels. And this is because that oxygen can't get into that area that's supplied by that blood vessel. And then it starts causing damage to that tissue. And then, of course, if we don't intervene quickly, that tissue can stop working and die.
So that's so important. And I think when we talk about this, thank you for clarifying that, because heart disease is not necessarily like blood pressure alone or cholesterol alone. Those are actually risk factors for heart disease. So let's dive a little bit into what the actual risk factors are for heart disease and stroke. Because when we talk about risk, we always divide it into modifiable risk factors and non-modifiable risk factors. So modifiable risk factors are things that we can change and we have control over. And non-modifiable risk factors are things that we cannot change. So things that we're basically born with. And this is really important because we know that 80% of heart disease is preventable if we can address those modifiable risk factors. So first off, let's talk about the things that we can't change. So non-modifiable risk factors are things like our family history. So if you have someone in your family who had heart disease or a stroke, especially at a younger age, your risk may be higher as well. I know this myself in my family. I have first-degree relatives who have had strokes and heart attacks, and so I'm very aware of my risk is something that I can't change that, but I can be aware of that risk. Age is also a risk factor that's really important. So as we get older, our risk of heart disease increases. Sex is also important in terms of men have a higher risk of heart disease at a younger age, but women catch up after menopause. And that's a really important distinction, which is why we see midlife and beyond such a critical time to understand women's risk factors for heart disease. Ethnicity is also a really important piece. I'm very aware of, certain groups like Indigenous folks, South Asians. We are at higher risk of heart disease. And this is something that, is really close to home for me. And this is where we actually use different risk calculators for people of different ethnicities because we know that they may carry a higher risk as well.
And so, as two South Asian women, I'm just as acutely aware of this risk as you kind of mentioned you are. So let's talk about modifiable risk factors because these are things that we can prevent. And so in people like you and I that already have that underlying risk because of, family history potentially or ethnicity, things that are not in our control, it is important to have an understanding of things that you do have the ability to change your risk profile with. And so things that you can change include things like high blood pressure. So this, is very commonly known as the silent killer that damages blood kind of arteries or blood vessels over time. And so, having high blood pressure is not going to typically cause a heart attack in the moment, but over time, that high blood pressure damages the inside of those arteries and actually leads to a higher likelihood of that plaque formation. And so this is something that can be controlled with medications and lifestyle changes in consultation with your family doctor. Another similar thing is high cholesterol. So if there's more cholesterol in the blood, it leads to more plaque buildup in arteries. And then again, that can lead to a heart attack or stroke. And again, can be modified by lifestyle and medications with your family doctor. Smoking is another huge risk factor. So quitting immediately, actually right away, will lower the risk of of a heart attack or stroke. And then alcohol comes into there as well. And so chronic alcohol use, or even, as little as a few drinks a week can very much increase your risk of heart attack and stroke. Diabetes, of course, we know that this does increase the risk of heart disease significantly, but it is something that with good blood glucose control, modifications to your diet, things like exercise, and of course, medications can lower that effect of diabetes on heart disease. That kind of leads into the next one, which is obesity and inactivity. And so heart disease skyrockets with a lack of movement or a sedentary lifestyle and increased obesity, especially that kind of central obesity around the middle of our bodies. That's been shown to have an increased risk of heart disease and stroke as well. And then things like chronic stress and sleep. And so as two physicians, we are certainly very well aware of this.
We are chronically stressed and
we are chronically stressed
sleepers
and chronically tired. And so more and more studies are showing that stress and poor sleep do have an impact on heart health. And interestingly, there is some decent data to show that shift workers in particular do have a higher risk of heart disease as well. And so I certainly am looking at all of those other risk factors that I can modify as a shift worker to try to offset that risk for heart health as well. And so it is so important for our listeners to know that so much of heart disease, like you said, Sheila, 80% of heart disease is preventable. And in the ER, I very much see a different side of this because people often don't even know that they had high blood pressure or diabetes until it's landed them in the emergency department with chest pain.
So much so. And I think this is what's really important is that you don't necessarily feel the symptoms of heart disease before you actually have a heart attack or a stroke. And this is why knowing your numbers really matters. So knowing what your blood pressure is, knowing what your cholesterol is, knowing what your blood sugar is, these are not things that you necessarily feel, but you do need to get them checked out regularly. So what we do in our office, a large part of family medicine, is that we do preventative care. And this is where we screen for things like cholesterol, blood sugar, and your blood pressure as well as a review of your other risk factors. And so we screen for your cholesterol, blood sugar at age 40. And Generally, though, if somebody has risk factors, like we mentioned, Shaz, like the non-modifiable risk factors. So if somebody is South Asian background, if they're Indigenous, if they have a family history, I actually start screening them earlier for heart disease risk factors. So I will do it at age 30 instead of age 40. So this is a nuanced conversation that you need to have and think about. And if you don't have a family doctor, or you need to go to a walk-in clinic, or wherever you are, think about what your risk factors are based on what we just shared, and then think about, okay, when do I need to get tests? Now, generally, the general population, again, is at 40, but if you have risk factors of potential risks earlier in your life due to that other risk factor list that we mentioned, get checked out earlier. And from there, generally, once you start screening, we do it every 2 to 3 years.
I think that's a really important point. So for me, I have a few risk factors. I am South Asian. One of my parents has high cholesterol, and my other parent has high blood pressure. And like those two things run very much in each of their families as well. And so because of those risk factors that I do have, it is a conversation that I had with my family doctor, and I started getting screened in my 30s for, high cholesterol and high blood pressure. So it is important to have those conversations with your primary care provider, because sometimes, the only risk factor we think of is, do I have a family member that had a heart attack? And that's kind of the only one that sticks out in people's minds. But it's, like we mentioned, many, many more other risk factors that play into how screening starts and when screening starts. Now, I want to kind of take things back to the first part of Kellie's question. She asked about, she said she was in her late 30s. She asked about the effect of perimenopause and menopause in terms of their effect on the risk for heart disease in women. Can you tell us a little bit more about that, Sheila?
Definitely. So menopause can significantly affect heart health. And I'm so glad Kellie addressed this by asking that question, because we know that estrogen has a protective effect on the cardiovascular system. And when estrogen levels decline in menopause, and in perimenopause, we have fluctuating levels, it can lead to a potential increase in your blood pressure, your cholesterol levels change, and it increases the risk of developing heart disease, including heart attacks and stroke. And this is really related to, estrogen decrease can also cause a decrease in the flexibility of the arteries. So you get stiffer arteries, there's increased fat around the heart, and then there's potential for something called metabolic syndrome, which is where, because we see weight distribution change from subcutaneous fat, so the fat that you can kind of pinch on your body, to something called visceral fat, which is the fat around your organs internally, and we can get sort of central changes. And people will say this a lot. One of the big reasons people come to see us in menopause for menopause care is around weight distribution changes. That itself certainly has changes in how you see yourself, but it actually affects the risk of heart disease greatly and increases the risk of heart disease when we see that weight distribution change. And I think this is where we get into it a little bit further in our second episode when we talked about perimenopause. So I encourage everyone to go back and listen to that for a little bit more information on this.
Thank you for that. I think it's important that people understand the symptoms of a heart attack as well. And so when it comes to heart attacks, I think a lot of people still picture that classic, like Hollywood heart attack that we see in TV and film, where someone is clutching their chest, gasping for air, looks kind of gray and unwell, is sweating, but it's not often that obvious, especially in women. So can you tell us a little bit more about the symptoms of heart attack?
For sure. And I think this is something that you will see also in the Emerge more often than I do necessarily. But, what I see in my office is people who come in with subtle symptoms sometimes, and they don't think that this could be a heart attack. Now, the classic symptoms, like you mentioned, Chaz, are like the chest pain or tightness. People like put their hand over their chest, and they feel like an elephant is sitting on their chest. There's pain radiating to their arm or their jaw or their back. They may have also accompanying symptoms of shortness of breath, heart racing, and they get really sweaty and nauseated as well. Those are sort of the classic symptoms. So what do you see in the Emerge though, Chaz?
So I often still do see classic symptoms, but those are, like we've been talking about, typically in men. But then populations like women, Indigenous people, and those with diabetes often present, like you said, Sheila, with a lot more subtle symptoms that are easier to ignore as an individual, like, deciding whether you're going to come into the hospital or not, but also, potentially easier to be overlooked by a provider because it's not those classic symptoms. And so those less obvious symptoms can include things like fatigue. So just feeling more tired. I can't tell you the number of times I have seen, a middle-aged woman coming in being like, yeah, I feel tired. All of us feel tired. We just talked about feeling chronically sleep deprived. And so this is an important thing to pay attention to. Other things like feeling of indigestion or heartburn or nausea is one of these subtle signs of heart attack. Dizziness or lightheadedness is another subtle one. And then just so many patients come in, especially women, just saying that they feel off. They can't quite articulate what it is. Something doesn't quite feel right and they can't quite pinpoint what it is. And for me, I take that very seriously and do typically a pretty broad workup, including heart tests on these patients because of how subtly heart attacks can present in women in particular.
That's so important. I'm so glad that you do such a thorough workup, because I do think that many get ignored when they come in with these subtle symptoms.
Mm-hmm.
Another one that a lot of my patients will have are things like they just can't walk up the stairs like they used to, or they notice that they're getting a little bit more tired more easily when they're doing the same distance that they usually would. And that could also be a sign of something going on with the heart. So when somebody comes into the emerge, you touched upon this a little bit, Chaz, around like when someone comes in with symptoms, classic or subtle, what happens when they come into the emerge with a potential heart attack?
Mm-hmm. And so the saying in the ER or in medicine is that time is muscle. And so the muscle of the heart in particular. And so every minute you wait in seeking care leads to more heart damage because oxygen is not getting to that muscle, and that muscle is then dying, which can lead to a higher risk of death and also a higher risk of long-term heart function issues, which can also then shorten your lifespan in the long term. And so because of that, high risk situation, and because time is muscle, as soon as somebody comes in with symptoms that we think might be a heart attack, we get a heart tracing or an ECG immediately, because with large heart attacks, we can actually see signs of heart tracing differences or abnormalities that can immediately indicate that there is a big, bad heart attack going on. We also get blood work at the same time, because there can be more subtle heart attacks or smaller heart attacks that aren't seen on that ECG, but then can show up because of that blood test being positive. And so as soon as a heart attack is diagnosed either by a heart tracing or by the blood work, the priority is restoring that blood flow because of that lack of oxygen that's flowing through that muscle. And so that can either be done by a clot busting medication or putting in a stent to open up that blocked artery.
And I appreciate you saying time is muscle. And this is where it's so critical for people to get care as soon as possible. And this is where, women often delay seeking care, or they're misdiagnosed and sent home. And this can be really dangerous.
Absolutely. I mean, I can't tell you the number of times I've seen women who come into the ER who have either, ignored their symptoms, waited for hours or even days before seeking care because they've been brushing it off. And by the time they get to us, that damage has already been done, because once we kind of get past that point of no return, that damage to the heart becomes irreversible. And so that's why it's really important to pay attention to even those subtle symptoms, or even, a little bit back to Kellie's question, just like advocate for your family member to come into the ER if they are having vague symptoms.
So important. So if something feels off, don't wait, especially if you have risk factors like high blood pressure or diabetes. Always really important to seek out care. It's better to seek out care and just know that things are okay rather than missing something that could have catastrophic impact on your life. So how can patients advocate for themselves or their loved ones when they're in the emerge? It's busy. There's so many people waiting. What do you suggest, Chaz, when people come in?
Yeah. And so this ties us back to the second part of Kellie's question in terms of how to advocate for care. And so that advocacy starts with coming into the ER to begin with. And so whether it's you as an individual or you advocating for your family member to come in, whenever people come to the emerge, I always say, I never fault them for coming in. And I always, reassure them that it was the right thing by coming in, especially when it's anything that could be related to a heart attack. I want to see you. My colleagues want to see you, because we're better off, ruling it out and saying, nope, not a big deal. Like this was, chest pain from something else, but definitely not a heart attack, versus learning too late that it was a heart attack and then not being able to intervene in a timely fashion. Another thing I would say is, be sure to bring up, or don't be afraid to bring up your risk factors or family history to give that context to the provider that you're seeing, because sometimes, when things are rushed, it's easy to miss those things. And so please advocate for yourself by letting us know what your risk factors are and whether you do have a family history, because that certainly changes how we're going to approach things. When it is possible, having a family member there with you to advocate for you, to speak up, and also to take notes or ask questions that you might forget, because it is a very stressful environment to be in as a patient. And so it's really easy to forget things to ask, things to bring up, or even writing down things in terms of questions that might come up that you forget later as well. We are very lucky to have very accurate tests to rule out heart attack in the ER. So things like an ECG or blood test, but these two tests only tell us if in the moment a patient is having a heart attack. And so it is really important to advocate for follow-up with further outpatient testing with a cardiologist, like a stress test, for example, even if all those ER tests are negative, what it tells you is that, or what it tells us is that there isn't a heart attack, but it doesn't rule out cardiac disease or heart disease. That can require additional testing as an outpatient. That's important to ask about and advocate for too.
Absolutely. And, that reminds me to kind of bring up that, you may be having some of these symptoms before having a heart attack.
Mm-hmm.
And I think that's where primary care comes in as well. So seeing your primary care doctor or nurse practitioner to say that you might be feeling more tired or more weak, you might be getting chest pain when you're walking upstairs, those kinds of things alert me to say we should do a stress test. We should do maybe an echocardiogram to look at your heart structure. And these are things that we can do before you get to the emerge and hopefully prevent that heart attack from happening. So if you're having these subtle symptoms and you're not quite sure, always seek out support. I do always appreciate when my patients are seen in the emerge and emerge colleagues are referring over to cardiology. We always see our patients within a week of going into the hospital for anything heart related to make sure that they're getting proper follow-up, because it is critical that time window, because perhaps, like you said, Shaz, that window is in that moment that might not be happening. But especially if someone has risk factors or they're experiencing symptoms that might be something more serious, it's important to have that follow-up. So I really appreciate that you arrange those things as well, because sometimes it's faster when you arrange it than when I can arrange it as a family doctor.
For sure.
So I want to switch gears a little bit to stroke. This is something, so stroke is really important to discuss as well. It's also part of the heart disease umbrella when we talk about heart disease. I have a personal relationship to stroke. My mom had a stroke a few years ago. And I remember walking into the emerge and seeing her, because I was living in Toronto and she was in Edmonton, and the care was excellent in Edmonton. But when I came in, I saw her CT scan. My heart just fell, and
goodness.
and I could read it, right? I could see what was happening. And it was absolutely devastating to see the impact of this. And my mom had risk factors and we were working on that. But I think looking back and retrospectively, I'm like, I wish we did more. She's doing well now. So I feel really grateful that she's well. And she, but so many people struggle after a stroke. And I know that we're really fortunate. So let's talk a little bit about stroke, because I think this is where, this is another part of heart disease that we don't talk about enough. And this is and also a stroke is basically a disease of the blood vessels, but of the brain, the blood vessels in the brain. And stroke is sort of, instead of when you said time equals muscle, this is when time equals brain. And we have an acronym that we use to help people understand when they should seek care called the FAST acronym, which is the warning signs of stroke. And the F of FAST is if you notice that you're having any facial drooping. A is if you have any arm weakness. S if you have speech difficulty. And T is it's time to call 911 if you're having this. And I have to say, my dad did FAST on my mom when she had a stroke.
Okay.
And she had arm weakness and speech difficulty. And if you notice any of these signs, it's time to call 911. And I'm so grateful that he was able, she didn't realize it, that she was having a stroke, and he saw it.
And a lot of people, that's a good point, because a lot of people don't, it's a good point, because a lot of people in the emerge, it's their family members that have noticed them, or if the patient happens to look in the mirror in the morning, right?
Totally.
And sees that facial droop. But that's such a good point, because those symptoms are often unrecognized by the individual that's experiencing them.
So let's do it really quickly again, because I think it's important. So facial drooping is F, A is arm weakness, S is speech difficulty, and T is time to call. So you notice that you see more stroke than I do, Shaz. So tell us a little bit about what you see.
Yeah, and I think you really hit the nail on the head there. Time is brain, and recognition is the most important thing when it comes to preventing those long-term effects of stroke. And so essentially what's happening during a stroke is that the blood vessel supplying a particular part of the brain is blocked off, and you start losing oxygen to that part of the brain that's responsible for a certain function. So if it's a speech issue, the part of the brain that is responsible for speech is not getting enough blood flow. If it's your arm weakness, it's because the part of your brain that's responsible for that particular arm is not getting enough oxygen. And then what happens is over time, so as early as like minutes, as that oxygen is not supplied to those neurons or those brain cells, they start to die, and that damage can become permanent. And so the reason we say time is brain, because the quicker you can intervene and either dissolve the clot or remove the clot, the more likely it is that those symptoms can actually often be completely reversed. And so what that means is that speech is particularly important. And then of course, arm weakness as well. And so those are things that can cause quite a bit of disability over time if they aren't reversed. And the idea is that we want to get that intervention really quickly and then completely reverse those signs of stroke as quickly as possible.
It's remarkable. I imagine you've seen people have the reversal. Can you, if they get in on time? It is
Yes, it's fascinating to see it. So at the site that I work at, we give a clot busting medication for stroke, and it's so interesting to see. Like, we do a full assessment. We have the stroke neurologist come as well and do an assessment and make sure that there are no kind of risk factors or contraindications as to why someone could not have a clot buster. And if they check all the boxes, they get that clot buster, and you can see within, there's assessments along the way, and you can see that their speech is getting better. They're now able to use their arm. And then when you follow up with people after they have had an admission to hospital and have their rehabilitation, I've seen people that then, have a history of a stroke previously, like a large stroke previously, and come in completely normally functioning. It's because they were able to get to the ER and get that management extremely quickly.
That's amazing.
Mm-hmm.
And that's, again, goes back to time is brain and why it's so important to get in as quickly as possible. For folks who don't make it in as quickly as possible, there are other things that we can do, though. And so it's still important to seek out support. In family practice, what we often will see is something called transient ischemic attacks, where people may have a temporary loss of function. So they have numbness or they have weakness on one side of their body, but it goes away really quickly. Their vision changes for a moment. And those are still things that, even though they're momentary, they can signal that there's something bigger coming, which is why it's really important to get checked out when people come in to see us and they tell me that they're having something which might be, it's also called a mini stroke, is often the term that people call it. Mm-hmm. Then I can then help them around this to make sure that they're going to get the appropriate investigations done before something happens. Similar to what we talked about with heart attack, there are things that we can do. Your body is telling you something. If something is off, get help, because then we can make sure we do the proper investigations, potentially put you on the right medication to prevent a heart attack or stroke from happening.
And, to kind of wrap up this episode, Sheila, we've talked a lot about why women in particular are at higher risk and need to pay attention. So can you give us a summary of what it is about women in particular that puts them at increased risk of heart disease?
Certainly. So, we need to pay more attention as women because of certain hormonal differences that we know exist. In pregnancy is considered to be a high risk time potentially. And if you have pregnancy related complications like high blood pressure in pregnancy or gestational diabetes or diabetes of pregnancy, that can increase your future heart health risk in the future as well. So important to know. So my patients who have had diabetes or high blood pressure or something called preeclampsia, those are conditions which put you at higher risk later. And I keep a note on their chart to say, we're going to be starting our screening earlier for you and making sure that we address those modifiable risk factors aggressively to reduce your risk later on. Menopause itself, as we've talked about in this episode and previous, estrogen protects the heart. So when it drops, our risk goes up significantly. Really important in midlife to get checked out, know your numbers and get that help. Autoimmune disease is also one that we haven't touched upon, but it's basically conditions that increase inflammation in your body. So autoimmune diseases such as rheumatoid arthritis, inflammatory bowel disease, psoriasis, that's a skin condition, but it's an inflammatory condition. Pro-inflammation in your body increases the risk of atherosclerosis and increases the risk of heart disease and stroke. So also,
and it's important that women are much more likely to have autoimmune diseases 100%. Than men are, right? Which is why that's an important risk.
It is an important risk. And I think this is one that we kind of don't think about as part of our risk factor review. And finally, like you mentioned, Chaz, like chronic, like mental health and stress, anxiety and depression raises heart disease risk more in women than in men. And that's one that we really do want to address as well.
And then, from an ER perspective, we know that studies show that when women go to the ER, they're much less likely to get the same attention, the right tests, or the right treatments. And so women's pain is often dismissed. It's often brushed off. And that's why it's so important to advocate for yourself and for your family members when it comes to heart health and health overall. So Sheila, can you leave us off with our prescription for today's episode on heart health?
Absolutely. So our prescription for your heart health today is to know your numbers, so your blood pressure, cholesterol, blood sugar. Get some movement in daily. That we know that can be really helpful for heart disease risk prevention. Quit smoking, because we see it immediately reverse your risks if you can quit smoking. And there are options available for support that we can help you with around reducing smoking in your life, because it's hard to smoke to quit, but there are supports available. Prioritizing things like sleep. Certainly that's difficult if you work in a shift working setting, but prioritizing sleep can be helpful. Managing stress and also fostering, social connections and being together. Those are things that we know that can help your heart health in the long run and longevity. And for women specifically, I think it's important to always speak up and advocate for yourself and advocate for each other, because again, we are still catching up in the medical system around how much we know about women and women's health, and sometimes we are dismissed. And so we need to use our voices and get that help when we need it.
Thank you so much for that. So that's a wrap on this week's episode of the Doc Talk podcast. If this episode made you think twice about your own heart health or someone you love, please share it. It could save a life.
And if you have a question for us, please do send it our way. We love hearing from you, and we'd love to cover it in a future episode. So until next time, please take care of your heart. It's the only one you've got.
Thank you for tuning in to today's episode of the Doc Talk. A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. And please be sure to follow us on social media at the Doc Talk Pod to send us your questions.
And this episode is brought to you by Always Discreet. Our patients have to share that if they sneeze or laugh too hard, or even during a workout, there can be bladder leakage. There's no shame in this, and there are solutions. You're not alone, and there's no need to worry. Always Discreet is here for you. Many women experience urinary incontinence as they go through perimenopause and menopause. Nearly half of us may encounter leaks or accidents during this time, and by age 65, about 75% of women report experiencing some form of urine leakage. Yet it's a topic that we rarely discuss.
Always Discreet's Rapid Dry Core locks away even the biggest leaks with no wetness, no odor, and no visible lines, allowing you to stay active and confident. They stay in place comfortably and remain invisible under clothing. Check out the link in the description for an Always Discreet coupon and step confidently into this new chapter. Always Discreet, your dependable solution for bladder leaks.